Chapter 6, Medicare. The learning objectives for Lesson 6 are: 1. Explain the history of Medicare. 2. Explain eligibility criteria for Medicare. 3. Abstract important information from a patient's Medicare card. 4. Identify the benefits of Medicare. 5. List 5 federal laws adopted to increase health benefits for employed elderly individuals. 6. Explain various Medicare programs and other insurance coverage combinations. And 7. Name the federal program that relates to utilization and quality control of health services. 8. State the benefits for a participating versus a non-participating provider. 9. Explain the 2 different types of Medicare coverage policies that must be adhered to. 10. Explain when to obtain a patient's signature on an advance beneficiary notice of non-coverage. 11. Identify non-covered Medicare services. And 12. Define and discuss a Medicare prepayment screen. And 13. Discuss the different Medicare payment methodologies. 14. Explain the resource-based relative value scale system that Medicare uses to establish fees. 15. Explain how the Medicare Access and CHIP CHIP Reauthorization Act of 2015 will affect Medicare reimbursement in the future. 16. State the Medicare Mandatory Claim Submission Guideline. And 17. Define a Medicare Administrative Contractor and explain the responsibilities. 18. Determine the time limit requirements for transmitting a Medicare claim. 19. State the components of a Medicare remittance advice. And 20. Explain the importance of identifying Medicare overpayments. Policies and regulations. The Centers for Medicare and Medicaid Services is a federal agency within the U.S. Department of Health and Human Services. The CMS is responsible for the implementing of all rules, regulations, and health-related policies governing the Medicare program. The CMS is subdivided into 3 divisions: Centers for Medicare Management, and they oversee traditional fee-for-service for Medicare. Centers for Beneficiary Choices provides patients with information about Medicare programs. The Center for Medicaid and State Operations focuses on federal state programs like Medicaid, the State Children's Health Insurance Program, insurance regulations, and the Clinical Laboratory Improvement Act, CLIA. Eligibility requirements. Medicare is a federal health insurance program for the following categories of people: people 65 years of age and older who receive Social Security benefits, people 65 years of age and older who are retired from the railroad or civil service, disabled individuals who are eligible for Social Security disability benefits and who are in the following categories: 1. A disabled worker of any age, a disabled widow of workers who are fully or currently insured through the federal government, an adult disabled before age 18 years whose parents are eligible for or retired on Social Security benefits, children and adults who have chronic kidney disease requiring dialysis or who have end-stage renal disease, and kidney donors. All expenses related to the kidney transplantation are covered. The Medicare program consists of 4 parts. Medicare Part A hospital insurance is for the aged, disabled, and blind. Funds come from special contributions from employees, employers, and self-employed persons, collected along with regular Social Security contributions. A benefit period is a time for which payment for Medicare inpatient hospital benefits are available. Hospital equals 90 days for each period. A nursing facility equals 100 extended care days for each period. Hospice is a public agency or private organization primarily engaged in providing pain relief, symptom management, and supportive services to the terminally ill patients and their families, either in their own homes or in a home-like center. Respite care is a short-term hospice inpatient stay for a terminally ill patient to give temporary relief to the person who regularly assists with home care of the patient. Medicare Part B, medical and preventive care benefits. Part B of Medicare covers medical services and supplies that are medically necessary to treat the patient's health condition. Treatment can include outpatient care, preventative services, ambulance services, and durable medical equipment. It also covers the clinical laboratory services, home health care, outpatient hospital care, and blood. Medicare Part C, Medicare Advantage Plan. The Medicare Advantage Plan increases the number of healthcare options. The Part C goes beyond Parts A and B to increase choices for enrollees. Enrollees can get a high deductible insurance policy where Medicare pays the premiums and deposits money into a medical savings account for the patient's use in reaching the deductible. It is important for the medical office billing specialist to become acquainted with Medicare Part C insurance provisions because some patients may be eligible for Part C. In 2010, the National Healthcare Reform legislation froze payments to these plans with cuts in the following years. It is predicted that enrollees may lose some benefits, such as free eyeglasses and hearing aids. Plans available under this program may include the following: HMOs, the health maintenance organizations. Point of service is your POS plan. Preferred provider organizations, the PPOs. Private fee-for-service plan, the PFFS. And provider-sponsored organizations, the PSOs. The Medicare Medical Savings Account is the MSA. Medicare Part D. Part D covers prescription drugs for conditions not covered in Part A or Part B. There are two ways to obtain Medicare Part D coverage for these patients. Either join a Medicare prescription drug program that adds drug coverage to the original Medicare plan, or join a Medicare Advantage plan such as an HMO or a PPO that includes prescription drug coverage as part of the plan. A formulary is a list of drugs that a health insurance plan covers as a benefits. Effective on January 1st, 2006 is when the drug benefits started offering to the Medicare beneficiaries. Eligible for Medicaid and Medicare members pay no premium or deductibles for Part D. It is a tiered drug plan. And check Medicare information for authorization requirements. Railroad Retirement Benefits. Railroad Retirement Board offices maintain eligibility records for Medicare. Many prepayment plans make arrangements for Medicare to receive direct payments for services it furnishes under Medicare Part B. The Medicare Railroad Retiree carrier is usually a different regional Medicare administrative contractor than the standard MAC. Medical insurance premiums are automatically deducted. They're entitled to benefits for covered services at a qualified American facility. And some may be members of the Railroad Hospital Association, prepayment plans, and contracts with Medicare. Employed elderly benefits. Federal laws and regulations. The Omnibus Budget Reconciliation Act, OBRA, required that if an employee or dependent younger than age 65 years has Medicare coverage because of a disability other than ESRD, the group coverage is primary and Medicare is secondary. This act applies only to large group health plans having at least 100 full or part-time employees. Tax Equity or Fiscal Responsibility Act, or TEFRA, of 1982 established that an employee or spouse aged 65 to 69 years is entitled to the same health insurance benefits offered under the same conditions to younger employees and their spouses. The group insurance is primary and Medicare is secondary. TEFRA applies to employers with at least 20 full or part-time employees. Deficient Reduction Act, DEFRA. DEFRA of 1984, effective in 1985, was an amendment to TEFRA and stated that a spouse aged 65 to 69 years or an employee of any age is entitled to the same group health plan offered to younger employees and their spouses. The group's coverage is primary and Medicare is secondary. DEFRA applies to employers with at least 20 full or part-time employees. Consolidated Omnibus Budget Reconciliation Act, COBRA. The COBRA of 1985, effective in 1986, is another amendment to TEFRA, eliminating the age ceiling of 69 years. An employee or spouse age 65 or older is entitled to the same group health plan offered to younger employees and their spouses. COBRA requires that the third-party payers reimburse for certain care rendered in a government-run veteran and military hospitals. The group's coverage is primary and Medicare is secondary. COBRA applies to employers with at least 20 full or part-time employees. The Tax Reform Act. The Tax Reform Act was passed in 1986 and clarified certain aspects of COBRA. A spouse and dependents may elect to receive continued coverage even if the employee does not wish insurance coverage and terminates the plan. However, the spouse and dependents must have been covered under the plan before the covered employee terminates. Spouses who are widowed or divorced while receiving continued coverage must report such changes to the benefit plan administrator within 60 days of the employee's death to determine how many additional months of coverage are available. Additional insurance programs. Determining if Medicare is primary or secondary. Ask about other insurance. The patient might be covered by Medicare or Medicaid, also known as Medi-Medi, Medicare and Medigap, managed care plans, or even private insurance. Copy the front and back of the Medicare card. Ask about supplemental coverage. If you're not quite sure, call the carrier, and you want to make sure to bill it out correctly. Medicare Managed Care Plans. The Medicare Managed Care Plans are the HMOs, the health maintenance organizations, risk plans, cost plans, and carrier dealing prepayment organizations. The risk plan. Beneficiaries receive Medicare covered services from providers who are contracted members of an HMO network. Enrollees called restricted beneficiaries. The cost plan. Our beneficiaries receive Medicare covered services from sources in and outside of the HMO network. Enrollees are called unrestricted beneficiaries. Carrier dealing prepayment organization. It may be set up by a medical practice under contract to the government. Patient signs a contract agreeing to a monthly fee, usually $20 to $25. It's supposed to cover all Medicare copayments, deductibles, and non-reimbursable expenses. Utilization and quality control. The Quality Improvement Organizations, the QIO, is a state-based group of physicians reviewing cases for hospital admission and discharge, formerly known as professional or peer review organizations. The contracts with CMS to review are for medical necessity, the reasonableness, the appropriateness, completeness, and adequacy of care. The Federal False Claims Amendment Act is another federal law to prevent overuse of services and to spot Medicare fraud. It offers incentives of 15% to 25% of any judgment to informants who report physicians suspected of defrauding the federal government. Another name for informants are called the whistleblowers. Clinical Laboratory Improvement Amendments, CLIA, established federal standards, quality control, and safety measures for all freestanding laboratories, including physician office laboratories. When claims to MACs are submitted for laboratory services performed in the physician's office, the 10-digit CLIA certificate number should be entered into Block 23 of the CMS 1500 claim form. Payment fundamentals. In a participating provider agreement, a service provider or healthcare organization agrees to accept payment from Medicare. Participating providers must accept assignment for all claims. Accepting assignment means the patient has signed a statement to have Medicare send payment directly to the provider of services. The non-participating physician is a provider or healthcare organization that does not have a signed agreement with Medicare and has an option about assignment. The service provider may decline assignment for all services or accept assignment for some services and collect from the patient for other services performed at the same time and place. An exception to this policy is mandatory assignment for clinical laboratory tests and services by physician's assistants. Prior authorization is a requirement for the healthcare provider to obtain approval from an insurance carrier to provide a medical service. Generally, traditional Medicare does not require prior authorizations. Waiver of liability provision. An advance beneficiary notice is a written notice you must issue to a fee-for-service beneficiary before furnishing items or services that are usually covered by Medicare but are not expected to be paid. The ABN allows the beneficiary to make an informed decision about whether to get the item or service that may not be covered and accept financial responsibility if Medicare does not pay. You will have the patient sign it if you expect Medicare to deny payment entirely or in part. Refer to the National Coverage Determinations, the NCDs, or the Local Coverage Determinations, the LCDs, to determine which services require an ABN. Elective surgery estimate. The term elective surgery means a surgical procedure that can be scheduled in advance, is not an emergency, and is discretionary on the part of the physician and the patient. A non-participating physician who does not accept assignment for an elective surgery for which the actual charge will be $500 or more must provide the following in writing: the estimated fee for the procedure, estimated Medicare approved allowance for the procedure, and the difference in the physician's actual charge. Chronology of prospective payment system. The Social Security Amendments of 1983 is hospitals treating Medicare patients are reimbursed according to the pre-established rates for each type of illness treated on the basis of diagnosis. The Deficit Reduction Act, DEFRA, is participating physician program that offered incentives to participating physicians and froze the fees of non-participating physicians. The Omnibus Budget Reconciliation Act of 1987 introduced the maximum allowable actual charge formula. Medicare reimbursement. The DRGs matters to the practice because they are the diagnosis-related group numbers that establish the rates of payment for each type of illness. A reasonable fee is the amount Medicare participating providers agree to accept for a given service. The patient may only be billed 20% of the Medicare allowed charge if the physician accepts assignment. The resource-based relative value scale is a system that Medicare uses for establishing fees. This system takes into account the work value, the overhead expense, and malpractice values for all current procedural terminology codes that are published in the Federal Register each November. Healthcare Common Procedure Coding System HCPCS Level 2 codes are used when submitting a claim for certain appliances and procedures for which Level 2 codes rather than CPT procedure codes are indicated. The Recovery Audit Contractor goals are to identify Medicare underpayments and overpayments and recover overpayments using automated review and complex review. The RBRVS formula. The RBRVS is designed to create fair reimbursement. It involves choosing a HCPCS or CPT code, using the relative value unit, the RVU amounts listed in the Federal Register for work value, practice expense, and malpractice value, and multiplying each by the geographic practice cost indices, the GPCIs. Then, to obtain the total adjusted RVU, add the three amounts together. Finally, to discover the amount that's allowed for this code, multiply the annual Medicare conversion factor by the HCPCS/CPT code's total adjusted RVU amount. Prepayment screens. If the claim was previously submitted for the procedure performed in the allotted time frame by another physician, the claim will be downcoded or denied. Medicare limits the number of times a procedure can be billed during that specific time. Computer screens triggers suspension of processing. 3 initiatives. The first one is the correct coding initiative. This is to eliminate unbundling or other inappropriate reporting of CPT codes. The second one is the Physician Quality Reporting Initiative, a pay-for reporting program for providers who bill under Medicare Part B. The Recovery Audit Contractor Initiative was originally created and a demonstration project that became permanently implemented when Congress enacted the Tax Relief and Healthcare Act of 2006. This extended the RAC initiative to all 50 states by 2010. It was created to identify Medicare underpayments and overpayments and recover overpayments using automated review and complex review. Claim submission. You must determine the local coverage. MACs and FIs, which are fiscal intermediaries. Now, the intermediaries are organizations that handle claims from hospitals, nursing facilities, intermediate care facilities, long-term care facilities, and home health agencies. Agents are organizations that handle claims from physicians and other suppliers for services under Medicare Part B. You must have provider identification numbers when submitting claims. Patient signature authorization. You must file your claims in a timely manner. And paper and electronic claims. Patient signature authorization. Signatures must be retained. These are called signature on file or SOFs. Now, there are special considerations in obtaining and filing the patient's signature authorization. The SOF situations is a literally or physically handicapped patient, confinement in a facility, a Medigap claim, a deceased patient, or a Medi-Medi claim. Time limit. Beginning October 1st, 2009, providers no longer have 15 to 24 months to file and must submit claims within 12 months of the date of service. There are 4 exceptions to which patients are allowed to submit claims to Medicare. 1, services covered by Medicare for which the patient has other insurance that should pay first. Services provided by a physician who refuses to transmit the claim. Services provided outside the United States. And situations in which DME is purchased from a private source. Claim submission. With your claim submission, you've got Medicare and Medicaid claims, Medicare and Medigap claims, Medicare and employer supplemental insurance claims, Medicare supplemental and Medicare supplemental payer claims, claims for deceased patients, and physician substitute coverage. With your Medicare and Medigap claims, to ensure the crossover of Medicare and Medigap claim for paper claims, complete blocks 9 through 9D on the CMS 1500. Claims for deceased patients. Nothing can be done about the open balance on the account until the estate is settled, and then Medicare will pay. 2 ways to submit billing for a patient who has died is the participating physician accepts assignment on the claim form and or electronically transmitted claim. The non-participating physician does not accept assignment, bills Medicare, and submits the following: the CMS 1500 signed by the estate representative who is responsible for the bill, a statement or claim for all services provided, name and address of the responsible party, and the provider's statement signed and dated refusing to accept assignment. After the claim submission, the remittance advice or the RA. Some of the information on the remittance advice will be rather if the claim was paid in full, the allowed amounts, the disallowed amount, if the claim was transferred to another carrier, etc. The Medicare Summary Notice to MSN is a document that's sent to the patient that is similar to an RA, identifying the same items related to the claim. Beneficiary representative and representative payee. When posting payments, you want to watch out for possible Medicare overpayments. There are several different types of scenarios that could happen. The carrier processes the charges more than once. The physician receives duplicate payments from both Medicare and a secondary payer. The physician is paid directly on an unassigned claim, and the payment is made on erroneous information. You want to make sure to review and the redetermination process. And this concludes the lecture of Chapter 6, Medicare.